Okay, so activity 11 is the respiratory and the digestive systems. We're getting down to the very end, so congratulations. And the upper respiratory tract, basically table 11.1, is everything above the larynx. And we'll uh, talk about the larynx when we do the lower respiratory tract. But the upper respiratory tract, starting at table 11.1, and this is just a slideshow that's in your Canvas modules. So we have our nostrils and then the vestibule. And the vestibule is basically just the opening in your nostril. It's kind of like the pupil in your eye. It's just an empty space. So that's the vestibule. And then we already talked about the concha. And so you remember that the concha are those pieces of the skull that have the pseudostratified columnar epithelium lining them, and they're going to warm and moisten the air. So we've got the superior nasal concha, the middle nasal concha, and the inferior nasal concha. And then just this area below each concha, or concha, however you want to pronounce it, is called the meatus. So just below the superior nasal concha, we have the superior meatus, middle nasal concha, and then just underneath it is the middle meatus, and then the inferior nasal concha and the inferior meatus. So above the hard palate, but below the inferior nasal concha is the inferior meatus. And then we learned about our sinuses also when we were doing this skull. So we have the frontal sinus, the sphenoidal sinus is the yellow, and then the ethmoidal sinus is the teal color, and then our big maxillary sinuses here. So from this picture right here, this is the frontal sinus, and then this big one right here is the sphenoidal sinus. You can't see the ethmoidal or the maxillary from that slide. So if you have a model that has like the fish tank head, if you remember that guy that we showed the big maxillary sinus on the other side of the face like this, we had this face and then it showed the other side with the eyeball, and that would show the maxillary sinus. And then if you remember on our torso model, the head there had the little dots, which were the ethmoidal sinuses. The pharynx is basically this shared space in the back of the throat. And I say shared because it just means that there is the potential for food or drink to go up into the nasopharynx, and then the oropharynx back here behind the tongue, and then the laryngopharynx or the laryngopharynx, which is the space behind the larynx. So they're just regions. So this upper red region is the nasopharynx, and hopefully you don't get food up here, but it's a possibility if you're laughing or get startled while you're eating. Sometimes food will come out to this nasopharynx. And then the oropharynx, this yellow, is the shared space shared by both the respiratory and digestive tract. Normally it is shared. And then below the level of the epiglottis is this area of the laryngopharynx where hopefully only air gets down here. If you do get food or drink down here, then your body is going to try really hard to get rid of it by causing your trachea to spasm, which causes those coughing fits. So the hyoid bone is this little bone right here, and it is the actual division between the oropharynx and the laryngopharynx. So you can say that anything above the hyoid bone, but below the uvula is the oropharynx, and everything below the hyoid bone is the laryngopharynx. Also included on table 11.1, which we've already talked about as well, is the hard palate, which is that palatine process of the maxillary bone and also the palatine bones. And then the soft palate is this more, it doesn't have bone, it's just this tissue on the back of the throat. So if you open up your mouth really wide, you can see your uvula hanging down. That's part of the soft palate. So if this little section is tagged down here, we're usually referring to the uvula, but if this whole region is circled, we're looking for the soft palate. So the uvula is a part of the soft palate. So you can also see the larynx on this picture. So again, everything that is below the epiglottis and the hyoid bone is considered your larynx. So you've got your Adam's apple or your thyroid cartilage here, and we'll look at these in the next slide. But it's basically where your voice is produced. And then below that is the tube that goes into your lungs, which is the trachea. So the next picture here is the cartilages in your larynx. And all of these cartilages are covered by muscle and soft tissue. So they wouldn't look like this in the body. You would have to clean off all the muscle and soft tissue. But this is an anterior view. So here is your epiglottis. And again, we looked at the epiglottis. Sorry, I don't know if I did look at the epiglottis, but the epiglottis is right here. And it's the flap that comes down and closes over your trachea when you swallow, so that food will go down your esophagus instead of your trachea here. So the tube in the front in your throat is the trachea, and then the tube in the back of your throat here is the esophagus. And the esophagus is able to expand, so which is why it looks so small here. And then the trachea, you'll see right here, it's got these rings. These are just cross sections of the rings that help keep it open. So if you have trouble remembering which one is in front, just think of like a tracheostomy. They just make a little incision between the cricoid cartilage and these tracheal rings, and they will just right under the skin be able to pierce through the trachea and put in an artificial airway. So again, this is the larynx and then the trachea. So here's our epiglottis, and this is from the posterior view. This is what it looks like. And if we have these big larynx models in the lab, but this little epiglottis can bounce up and down in the lab. It's like a little springboard, a little diving board. And this bone right here, this is your hyoid bone. So this is the only piece of bone in this entire model or this entire structure here. So everything else is either cartilage or soft tissue or membranes or muscle, ligaments. So the hyoid bone here. And this is a membrane here that's going to connect the hyoid bone to this big, huge cartilage here, which is called the thyroid cartilage. And this point of the thyroid cartilage is called the laryngeal prominence. So the laryngeal prominence is basically where your Adam's apple sticks out. So your laryngeal prominence, depending on how big it is how far your Adam's apple sticks out. So males, people born male, usually have a larger, more prominent laryngeal prominence than women do. And that is also another reason why men's men have deeper voices, and I'll show you that, how that's, why that's the case there. So this is the back side of the thyroid cartilage. So you notice the thyroid cartilage doesn't go all the way around. It's only like a half moon shape here. There will be membranes that run along the back side here. And then you notice that we have a cartilage that does go all the way around right down here. So this first cartilage right here, you can see where it goes all the way around the back. This is called the cricoid cartilage. And this is the only cartilage of the larynx that it forms a complete circle. And so if you are familiar with how a patient is intubated, you know that they apply cricoid cartilage pressure or cricoid pressure. And the reason they do that is this view right here. Here's the cricoid cartilage. If it goes all the way around, if they push it down, then it closes off the esophagus. So the intubation tube or the little scope they put down there can go into the trachea instead of down into the esophagus. It's not a life-threatening thing if they do get into the esophagus. It just is in a critical situation. It's a time thing. So then as we go down the trachea, we have these tracheal cartilages. And these tracheal cartilages don't go all the way around either. They have a membrane in the back which allows for food to pass down the esophagus, so this esophagus expands, and allows for this back wall of the trachea to come in a little bit to allow for food to travel down the esophagus. So what else do you need to know from this picture? You need to know these little cartilages in the back. This cartilage right here, and I'll see if I can find a picture that doesn't have the muscle in it, is called the arytenoid cartilage. And there is a little horn-shaped cartilage on top of it, which is called the corniculate cartilage. So let me switch PowerPoints here and see if I can find a better picture. So this is my PowerPoint. And I don't have a better picture here. Unfortunately, I've never had to test off of pictures on this. I've always been able to use a model. So let me see if I can find a picture of a model. Okay, so here is a picture of the model that is similar in our lab, and you'll probably see something similar maybe on the quizzes. So this is the back side here again. So here's this thyroid cartilage, the cricoid cartilage, the the tracheal cartilages, the epiglottis, and we have these two cartilages right here, which are the arytenoid cartilages. And then on the top of the arytenoid cartilages, there's these little teeny corniculate cartilages. And some people think they look like little tiny candy corns. And this one looks like a big A. So arytenoid are the bigger ones. And then corniculate are the little ones right on top here. So from the front, this is the hyoid bone. This is the epiglottis, the thyroid cartilage. The laryngeal prominence would be right here. Again, the cricoid cartilage and the laryngeal, I keep saying that, the tracheal cartilages. Okay, so this view right here is looking down from the top of the larynx. So if you were looking down at somebody's throat with a scope, this is what you would be seeing. So you would be seeing something that does not look this nice, but this is what it would look like. And this is what's underneath all of this. So this is with all the soft tissue and the membranes and everything attached to those cartilages that we already talked about. So this is the laryngeal prominence right here. These are the arytenoid cartilages, and these little ones on top are the corniculate cartilages. And you'll see that there are actually ligaments that span from the inside of the laryngeal prominence to the arytenoid cartilages specifically. And the arytenoid cartilages form a joint here with the cricoid cartilage, and they are able to move back and forth. There are muscles attached back here too that we use to speak. So the ones on the inside here, and if you were to look at it from a side view, these inside ones would be a little bit lower down in the throat as well. These are the vocal ligaments, and these ones that are a little bit up higher and a little bit more to the side are the vestibular ligaments. So I'm going to switch to a different view here and show you this from the side. So this grainy picture here is showing you that view from the side. So you were looking down into the larynx from the top, and this first piece you see right here is where the vestibular ligament is, and it's covered by a membrane. So when it's covered by a membrane, it looks like this from the side. So we have this first fold coming out, which is the vestibular fold, and the fold is basically the membrane that covers those ligaments. So those ligaments get buried in the membrane. So when you're seeing the fold here, what we're referring to is the actual membrane that covers the ligament. So the vestibular ligaments and folds are otherwise known as the false vocal cords, and their purpose is to protect the true vocal cords, which are a little bit deeper. And the true vocal cord is, the ligament, so the ligament itself, we usually call them the cord, but the ligament itself is the vocal ligament, and then it is also covered by a membrane, and it becomes the vocal fold. So here, the vocal fold comes out here. So this view right here, the one on the top is the vestibular fold, and the one on the bottom is the vocal fold. So the difference between the glottis and the rima glottis is the rima glottis is basically just the space between the vocal folds. So it's just a negative space. It's like your pupil or the vestibule of your nose. It's just the opening here. So it changes its shape based on the opening here. So a more narrow rima glottis will create a higher pitched sound. And the glottis is basically the vocal folds and the rima glottis. So the glottis is the vocal fold plus the rima glottis. And the reason why men have a lower voice than females typically is because the distance between the inside of the laryngeal prominence is since their laryngeal prominence is more pronounced and more facing anterior, it creates longer vocal cords on the inside. And so you think of like a bass. So the longer strings of a bass versus the strings of a violin create a deeper sound. So that explains why men typically have a deeper voice than women. So this is the model, and I've seen it pop up on the quizzes. And this view right here is the same thing we were just looking at. So this line right here is the vestibular fold, and the ligament is buried in that membrane of the vestibular fold. This line right here, the white one, is the vocal cord or the vocal ligament, and it is covered by this membrane here, which is called the vocal fold. And we're going to look at this model again when we do the bronchial tree. So we're moving down the trachea, and at the level of the sternal angle here, right here, the trachea is going to bifurcate into a right and a left main bronchus or primary bronchus. And it's the screen over here. And these are contained within the mediastinum. And then on the right, those main bronchi are going to give way to 3 smaller lobar bronchi. And the lobar are also called the secondary bronchi. There are 3 of them on the right and 2 of them on the left. So they correlate with the amount of lobes there are. So we'll learn that there are 3 lobes of the lungs on the right and 2 on the left. Kind of like in the heart where we have the valves, the tricuspid on the right and the bicuspid on the left. Kind of follows the same pattern. So smaller than even the lobar bronchi are the segmental bronchi or the tertiary bronchi. They're the yellow ones over here. And they do have names. You don't have to know the names of them. But at that point, we're starting to get embedded in the lung tissue here. So you won't be able to see those segmental bronchi if you were just looking at an intact lung. And then the segmental are going to get even smaller, and the walls of these tubes are going to change a little bit. So the trachea has those tracheal rings, if you remember, and once you bifurcate and start getting into the bronchi, the tracheal rings are going to start kind of getting more flat, and at that point they're just called plates, but they're still surrounding the walls of the bronchi. And the smaller that we get, we're eventually going to lose that cartilage plate or ring, and the muscular wall is going to get a little bit thicker. So that allows us to have a little bit more control over how dilated our bronchioles are. So a bronchiole is basically the end of a bronchi. So the bronchi gets smaller, loses the cartilage plates, and at that point we are in a bronchiole with a thick, smooth muscular wall. And the bronchioles are going to get even smaller to what is called a terminal bronchiole. And then even smaller than that is where the respiratory bronchioles are. So if we're following the pattern over here, so this is the left lung. So the left main bronchi, the 2 secondary bronchi, and then the multiple tertiary bronchi. And then we're going to get smaller into a bronchiole, and eventually into the terminal bronchiole, and then into the pulmonary respiratory bronchiole. So at that point, the inside wall of the bronchiole is changing. So we started as the pseudostratified columnar epithelium, and it's going to transition as we travel down the tube to eventually be just the simple squamous epithelium in these sacs down here. So between the respiratory bronchiole and these alveolar sacs here we're going to have these little ducts. So this, oops, let me turn on my brush here. So this little segment right here is called the alveolar duct, and it connects the respiratory bronchiole here to the alveolar sacs. And you can think of these pockets in the lungs, and there's obviously more than just this one track. We have a few 100 million alveoli in our lungs, and they're kind of like if you bought the grapes at the store. So there's a main vine, and then there's smaller vines that give way to clusters of grapes. So one cluster of grapes here would be called an alveolar sac. And then each individual grape would be an alveoli. And at this point, again, the alveoli are basically just simple squamous epithelium. So oxygen can pass easily from the alveoli through the wall, through the capillary bed wall, and into the capillary system. And then carbon dioxide can go in the opposite direction, and it collects in the alveoli, and then we breathe it out. So the capillary beds here, it's coming off of a branch of the pulmonary artery. So if you remember, the pulmonary artery was blue. It's going to travel alongside the bronchi into the bronchioles, and it's going to get smaller and send off branches into what are called the arterioles, and then at that point we are in the pulmonary capillary bed. So then oxygen is going to come into the capillary system, carbon dioxide and water are actually going to leave the system, and those capillary beds are going to get a little bit bigger into what are called the pulmonary venules. You can see the pulmonary venule right there. And then those pulmonary venules are going to dump into the pulmonary veins, which will then end up in those 4 main pulmonary veins that end up in the left atrium. So here is a model of the alveolar sacs. And so you can see basically everything you saw in that other picture. So this little section is an alveolar sac. This is showing you where the alveolar duct is. This is a respiratory bronchiole and a terminal bronchiole here. And each of these individual sacs are the alveoli, and then the capillary beds, the pulmonary artery, and the pulmonary vein. Like we had in the heart, we have bags that the lungs are contained in within the pleural cavities. And again, just like with the heart, we have a visceral layer and a parietal layer. So again, it's kind of like the fist in the balloon concept, where it's a double layered membrane, and the layer that is attached directly to the lung is called the visceral pleura, and then the parietal pleura is fused with the underside of the rib cage. So when your ribs expand and they pull this parietal pleura, there is serous fluid in between the 2 layers in what's called the pleural cavity. And so it allows for the visceral pleura to be pulled along with the parietal pleura, which then causes the lungs to expand because that visceral pleura is attached to the lung tissue. So the lungs themselves don't have any muscle in them. It is the action of the rib cage and the diaphragm that's going to cause expansion of the lungs. So down here, again, is the diaphragm. So know this picture here for the different layers of the linings of the lungs. So now let's just look at the anatomy of the lung really quick. So this is the right lung and this is the left lung. This view is actually if you were looking down your armpit on lateral side of your thoracic cage. Um, and this part right here is facing the outside. And this view is what's facing the inside, facing toward the heart. So the lungs sit a little bit more off into our kind of our armpits than we think they do. And they sit a lot higher than people think. Just below the level of your collarbone, we have the top part of the lung, which is called the apex. And then the bottom of the lung is called the base. And like I said before, the right lung has 3 lobes and the left lung has 2. The left lung has a spot carved out for the heart called a cardiac notch. If you remember, the heart goes off to the left a little bit. So there are some divisions that you need to know. So this is the superior lobe, that's easy. And then both sides of the lungs have an inferior lobe, but the right lung has an additional middle lobe. So the lines between them, between the superior and the middle lobe, we have the horizontal fissure, and that's only on the right lung. And then on both the right and the left lung, we have the oblique fissure, and it's going in the oblique plane. So looking at the other side here, this area, this box area right here, is called the hilum. And it's basically like where it's the freeway system of the lungs. It's where everything's coming in and out of the lungs. So within the hilum, we have the primary bronchi on both sides, the pulmonary arteries, and then the pulmonary veins. So again, the hilum is just an area of the lungs where structures are coming in and out of the lungs. And there's also going to be some lymph vessels in there, but you just need to know the pulmonary bronchi, the veins, and the arteries. So this is our model of our lungs, and you might see a different one on the quiz, but it's pretty similar. Again, you've got the 3 lobes on the right, the 2 on the left. This weird looking thing down here is the diaphragm. So I think I did notice that was a quiz question. It's kind of goofy looking, but that down here, that is the diaphragm. Moving on to the digestive system. So we have our main digestive organs here that we're going to learn. And then we have accessory organs. So our accessory organs are basically your salivary glands, your teeth, your tongue, your liver, your gallbladder, and your pancreas. And everything else we learn is one of the main organs. So starting in the mouth, we have obviously the upper and lower lips. And then we have what's called the labial frenulum. So the frenulum is just this little attachment here to the gums from the lips. And you've got an inferior one as well. And the opening to the mouth is called the vestibule. We did have a vestibule of the nose, if you remember. And then obviously we have teeth. So you don't need to know the different teeth, but they do have different names. And then we have the gingivae, which is basically your gums. And the hard and the soft palate. So we kind of already talked about the hard palate, and then the soft palate back here, which includes the uvula. And then your tongue, and the tongue is a lot bigger than you think. But it is tied to the bottom of your mouth with this lingual frenulum. So babies that are considered tongue-tied, this frenulum is too tight that they can't raise their tongue to the roof of their mouth. So they have improper swallowing. So this little lingual frenulum gets cut. and it can be cut later in life. We're always bonking our chins or something. So by the time you get to be an adult, one of these three frenulum or all of them are going to be cut at some point just from having accidents. And then we have what are called the tonsils. Tonsils that are on either side of your tongue are called the palatine tonsils. And if you were looking in a mirror and you open your mouth really wide, they're usually tucked behind this little wall right here. But if you have chronic illnesses of the upper respiratory, or even strep, these tonsils will start to get inflamed and swollen. So tonsils are basically um, similar to lymphatic tissue, but they're part of the lymph system, and they trigger your immune system. So if you are inhaling through your mouth or you're digesting food that um, has pathogens in it, they will send a signal to your immune system to respond. So an overreaction to immune response causes these tonsils to keep swelling, and at some point they will grow out so far as to even touch each other, which is called kissing tonsils, and that could cause sleep apnea. And so there's a couple of reasons why we would have these palatine tonsils removed. Obviously, if they're a collection area for bacteria, or if they are swollen to the point that they're touching, and they're rated on like a scale of 1 to 4 on how far they come out from behind this little wall right here, and 4 would be all the way to the middle. So these are the ones you think of when you're thinking of your tonsils being removed. This view right here shows you, so you can see one of the palatine tonsils on this side here. And then we also have one called the lingual tonsil. And the lingual tonsil is on the back of the tongue right here. Sorry, I had to think to myself for a second. So it's on the back of the tongue, really far down. I mean, you can't really see it. And then we have one that's actually on the roof of our nasopharynx, which is called the pharyngeal tonsil. And this one is sometimes referred to as an adenoid. So if you have a tonsillectomy and adenoidectomy, they're referring to this as the adenoid. So just know those three tonsils. So this picture is showing you your salivary glands. And your salivary glands, if you remember, they're one of those accessory organs. They are located, there's two big ones that are located on top of your masseter muscle. So if we were looking at the cadavers, this parotid salivary gland is sometimes mistaken for the masseter muscle. It's huge. It sits right on top, and then it has a little duct that travels in and dumps in between the inside of your upper cheek and your gums. Again, these are on both sides. And then you have a sublingual salivary gland that is below your tongue, kind of behind your teeth. And it has little ducts that come up through the bottom of your mouth. And then we have the submandibular salivary gland. And this one is deep, kind of near where the hyoid bone is. You look deep up into the throat from a posterior view on the cadavers. Sometimes we've got this one dissected out, the submandibular salivary glands. And their duct runs up and empties right behind the front teeth here. So this is how you gleek, is you milk this salivary gland with your tongue, and then it comes out right here, right behind your teeth. Haven't figured out how to do it myself, but it's a nice, fun, stupid human trick. We're going to continue on down the esophagus. So you chew up your food. Your salivary glands are going to produce enzymes that are going to start dissolving your food, and then you're going to chew, swallow, and then a bolus is going to travel down your esophagus. And where your esophagus meets the body of your stomach is called the cardia. It's right around the level of the heart. In fact, this sphincter, or this narrowing of muscle here, is called the cardiac sphincter. It's also called the inferior esophageal sphincter. So either of those would work. And if you remember, the diaphragm sits on top. So the esophagus passes through the diaphragm. And this upper part of the stomach is called the fundus, and the fundus sits right up underneath the diaphragm. So then you have these two curves, and we kind of talked about these curves when we did the blood vessels. The inside curve is called the lesser curvature, and the outside curve is called the greater curvature. And then the stomach, it's actually not as nice and kidney bean shaped like this. It's actually just more flat and banana shaped in my opinion. But where it starts to narrow here at the bottom is called the pylorus. And at the end of the pylorus is a little narrowing of the muscle wall, and it is called the pyloric sphincter. So the inside of the stomach has a modification of the inner wall where it forms these folds in here. And these are called gastric folds, and they allow for expansion of the stomach. And within those gastric folds are like the gastric pits and all the different types of histological features that, thank goodness, you don't have to worry about in lab. But I'm sure that it'll come up in lecture. So after the pyloric sphincter is where the duodenum begins, and the duodenum is the first part of the small intestine. But let's talk about the greater omentum and the lesser omentum first, and I'm actually going to talk about the mesentery proper while I'm at it. So our digestive organs are also encased in a bag, just like your heart and your lungs were, but it's not a nice, neat little bag like the others. It kind of does a weird shrink wrap action. So you've got, if you remember the picture of the sideways picture of the different mesenteries of the peritoneal cavity, the peritoneal cavity, the linings of that peritoneal cavity are these omentums. So the liver gets wrapped up in peritoneum, which is another name for the bag that surrounds the organs. The peritoneum, and then the two layers of the peritoneum come together and merge together, and then they engulf the stomach, and then they merge together again and continue on and form a sheet that covers all of your small and large intestine. So the one that spans the little sheet, dual membrane sheet that spans between the liver and the stomach, the lesser curvature of the stomach, is called the lesser omentum. And this one that covers your abdominal cavity is called the greater omentum. So on our torso model, the greater omentum they show as looking like this. It's just an apron. Clearly this is half of it, that sits over the top of your abdominal organs. So if you were to have an abdominal surgery, they would need to cut through your skin, the underlying adipose tissue, your abdominal muscles, and the rectus sheaths, and then they would have to cut through these greater omentum, and then you would be in the abdominal cavity. So the small intestine also have a little encasing around them, and where the two layers of the encasing are merged together, it forms this fan shape that keeps the small intestine all tightly compact. So just not like in the horror movies where someone gets disemboweled and all their guts come spilling out. Your intestines are organized within these mesenteries, so you wouldn't be able to pull it out in one big long tube very easily. So this one that is between the small intestine, the loops of the small intestine, is called the mesentery proper. You can see here that the greater omentum, they flipped up the greater omentum, so it's revealing the abdominal cavity. So this image is from the McGraw-Hill Connect, and it's a mid-sagittal cut of the torso. So you can see the lumen of some of the tubes in the digestive system. But what I wanted to show you here is this is where the greater omentum sits in the abdominal cavity. And this is a cross-section of the liver, just kind of orienting you to what you see there. I also want to show you, let's see here, this view right here. So this is showing you the greater omentum. Between the liver and the stomach is the lesser omentum. And then here's a picture of the mesentery proper between the small intestine loops. So now going back to the stomach and the duodenum, remember right between those two is the pyloric sphincter. So the duodenum is the first section of our small intestine, and our intestinal tract is all one big long tube. And all that changes are the histologic layers. So every segment of the intestines has a different function. And so the walls of these organs are going to change. So the duodenum you're not going to be able to tell where the duodenum ends and the jejunum begins. But if you were looking under a microscope, you would see a difference in the layers of the walls. So the duodenum is connected to the stomach. It gives way to the jejunum, and then it finally ends up in the ileum. And the ileum is going to dump into the beginning of the large intestine, or what's called the cecum. So know that the ileum is where the small intestine is going to turn into the large intestine. So there are a couple of accessory organs that are going to dump into the duodenum. So the liver is producing bile, which helps digest fats, and the pancreas is producing what's called pancreatic juice. And both the bile and the pancreatic juice need to enter into the duodenum somehow. So let's look at a little bit closer view of what that looks like. So here is a picture of the beginning of the duodenum. This is the pancreas here. So we're missing our liver up here and our stomach. So there is a tube that is coming from the liver and the gallbladder that is called the common bile duct. And there is a duct there's actually a couple of them coming from the pancreas, but this biggest one is called the main pancreatic duct. And it's going to empty the pancreatic juice into the duodenum. So these two tubes merge together, and where they enter into the duodenum, so on the outside of the duodenal wall, is called the hepatopancreatic ampulla. So it tells you that hepatic coming from the liver, pancreatic coming from the pancreas. And they form this little, it's not really, it just feels like a little hardened area in the wall of the duodenum. And then where these two empty into the lumen of the duodenum is called the major duodenal papilla. So if you're looking on the inside wall of the duodenum, where the juices come in is the major duodenal papilla. So make sure you know the difference between the hepatopancreatic ampulla and the major duodenal papilla. So the inside wall of the small intestine has an interesting feature. So if you remember, the stomach had the gastric folds or the gastric rugae. The inside wall of the small intestine has what are these called these circular folds. And they're just these ridges inside the small intestine. So if you were to look at these under a microscope, you would actually see there's ridges on top of ridges. And so it increases the surface area by millions of times, which allows for increased absorption of nutrients from the small intestine. So that's what's happening in the small intestine is the bolus or the little chunk of food that you swallow is going to turn into what's called chyme in the small intestine, whereas the nutrients are being pulled out. And you also have some white blood cells, patches of white blood cells in here that are going to pick up on any pathogens that are flowing through your digestive system. So this is the esophagus, this is the cardiac sphincter or the inferior esophageal sphincter, and then the different parts of the stomach, the pylorus, the pyloric sphincter, and then this is the duodenum. So what you can't see right here is this is the pancreas, and there's the common bile duct, and you could actually see on this model where the two merge together to form the hepatopancreatic ampulla on the outside of the duodenum, and then on the inside of the duodenal wall you can see the major duodenal papilla. You can also see the circular folds in the duodenum, and just FYI, the jejunum and the ileum also have those circular folds. You can kind of see it right here on this model. This particular model also shows the greater omentum. If you see something strange up here by this transverse colon, it might be the greater omentum. I'll have to take a look at the model and the quizzes. And then the ileum right here is going to give way into the colon. But let me show you one more model really quick. So we may have a model similar to this. Here is the pancreas. This is the gallbladder up here. So this is the liver would be up here. So the main pancreatic duct would be the number 9 in this picture. And the common bile duct is this, or sorry, yes, common bile duct would be the number 7 here. And the two will merge together, and where this 10 is at is where the the hepatopancreatic ampulla would be. So 10 here is the hepatopancreatic ampulla. And then where it dumps into the duodenum on the inside is the major duodenal papilla. So those are the things that you would need to know off of this model. You can also see on this model there's vasculature to the spleen. This is the spleen over here. It's not a kidney. The kidneys are back behind it. So I've seen that asked on this question before, these vessels over here that feed into the spleen. And then table 11-7, we're going to be going into the large intestine. So this is where the ileum leaves off right here. So we're missing all of the small intestine in here. Where the ileum is going to merge with the cecum, or I guess continue with the cecum because it's still all one big tube, is at the ileocecal valve. So this opening right here is where the ileum dumps into this big pouch right here, which is called the cecum. This little thing hanging off right here is the vermiform appendix. So that's your appendix right there. So this is going to travel up, across, down the left side, and then it's going to form this S curve and then empty through the rectum and the anus. So that's the direction that contents are going to travel, is up the right side, across to the left, and then down the left side. So sometimes you can tell that your appendix is going bad if you have lower right quadrant pain, because that's where this vermiform appendix is. So the colon is a continuation of the cecum here. And we have the ascending colon, the transverse colon, and the descending colon. And then we have the sigmoid colon. And like I said, the rectum and the anus. So the muscular wall of the large intestine has a modification in it, which helps things move through the colon. And it's called the Taenia coli. And the Taenia coli is basically this muscular band that's on the outside of the large intestine here. And there are little pockets, and these pockets don't go all the way through, the walls don't go all the way through, so these aren't complete segments, but there's these little pockets along the large intestine, which are called haustra. So some people like to think of they're little poop houses. So by the time you're getting into this area, the large intestine, its job is to fine tune your poop and pull out the water that you need and keep it in your circulatory system and excrete what you don't need. So these haustra sometimes give the poop this shape when it comes out. But again, there's just these little pouches on the outside. Back to this model, here is the cecum, and it's kind of small in there, but the ileocecal valve would be right here. This is the vermiform appendix. And then this is the ascending colon, the transverse, the descending colon, the sigmoid colon is right here. And this grayish, light gray line on here is the Taenia coli. And you can see the little haustrum, or the little poop houses. And you can see the rectum and the anus here too. So the rectum is kind of the last resort, the last chamber that poop is held before you poop it out. And the anus is obviously where the poop comes out. Okay, last but not least, table 11-8, the liver. There are 4 lobes of the liver. The biggest one is the right lobe, and this is the left lobe. So this is what you see if you're looking into the anterior view of the abdominal cavity. If you flip it over and look at the back, you'll see here this is the inferior vena cava, and this is the gallbladder where bile is stored. And between this fissure right here and the gallbladder is the quadrate lobe, and between this fissure and the inferior vena cava is the caudate lobe. So however you remember those two, I don't know, but I just always remember somehow that the quadrate is next to the gallbladder. So there is this fibrous membrane that is between the right and the left lobes that comes down, separates the 2 lobes, and then coils in on itself. The part between the 2 lobes is called the falciform ligament, and where it coils in on itself at the bottom is called the round ligament. So you can also see the falciform ligament from the back. So where things are entering and exiting the liver is called the porta hepatis. So the 3 different parts of the porta hepatis is this vessel right here, which is the hepatic portal vein. And then we have the hepatic artery proper. And then here we have the common hepatic duct. So those 3 structures are coming in and out of the liver in the porta hepatis. And I'll show you this in another view. So this picture, if you remember, is where we learned the hepatopancreatic ampulla and the papilla. So this picture right here is showing you the gallbladder. So these 2 tubes right here are coming from the gallbladder, or from the liver. So bile is being produced in the liver, and it's being sent down through the right and the left hepatic ducts. They merge together to form the common hepatic duct. And that is what you're seeing in the porta hepatis on that model, is this little segment right here. So, where the bile is going to enter into the gallbladder, this is actually a two-way street because you've got bile coming in, being stored, and then being sent out when we need it. So this little two-way street is called the cystic duct. And so if there is a gallbladder on the liver model, the tube that's connecting to the gallbladder is called the cystic duct. And then where the cystic duct and the common hepatic duct merge together is the common bile duct. And the way that I remember hepatic versus bile is the hepatic duct is closer to the liver. So hepatic stands for liver. That's how I remember which one is hepatic and which one is bile. So the common bile duct is what merges with the main pancreatic duct of the pancreas to form the hepatopancreatic ampulla. There's also another little accessory duct right here. So that this is the accessory pancreatic duct right here.